Wonderful. Good afternoon, everybody. It's 1:30. It's about time to start. We want to be right on time because we have a lot of things to discuss and hopefully learn from each other. My name is Marco Valgimigli. I'm coming from Switzerland, Lugano, Cardiocentro Ticino, and it's my privilege to welcome you to this sponsor session, which is entitled Making Treatment and Management of Complex PCI Easier with Cre8 EVO. These are my disclosures, and this is the agenda for today. I am joined today by very distinguished faculty, colleagues and friends. We have Scott Harding from New Zealand as a moderator and presenter as well. Discussant and case presenters, we have Professor Yong Chil Kim from Korea, Rafael Romaguera from Spain, and Gennaro Sardella from Rome, Italy. And last but not least, our magic chat master, Desh Istvan Ferek, who's going to help you interact with us, but don't be shy. Use the microphone. We have two standing microphones. I will have a rowing one in case you don't want to stand up. So the stage will be set by Scott, who is going to deliver a wonderful talk shortly about what are today's boundaries in complex PCI and complex patients. Really a wonderful talk. I had the privilege to have a preview too. And then we will have three case presentation, each followed by discussion, but also discussing the case every time there is an angio being presented, and I will wrap up the session shortly thereafter. So with that said, I think I can start loading Scott's presentation and again give him the stage. Thank you very much.
Thank you. It's fantastic to be involved in this complex PCI session. As you heard, I'm going to be talking about what are today's boundaries in complex PCI and complex patients. I do have some disclosures. So recently, this concept of CHIP, or complex high risk but indicated patients, has emerged. And that's really what we're talking about in this concept today. And these are defined by a number of things. Patient characteristics such as diabetes, renal impairment, lesion characteristics, calcifications, CTO, bifurcations, and also hemodynamic criteria. And often these patients have a combination of these, which puts them at high risk of complications, but makes the intervention complex. The real challenge for us is that many of these patients don't get intervened upon, and if they do, then they may not have good outcomes, and that's a real challenge for us. Diabetes continues to be a problem for PCI. We know that diabetes increases the risk of stent thrombosis, it delays healing and increases inflammation, it causes restenosis, we get more edge problems because of diffuse disease. And so consistently, studies have shown that if you're a diabetic patient, you have substantially worse outcomes than if you're a non-diabetic patient. So what can we do about that? Is there a way that we can address this? Well, clearly, a number of randomized controlled trials have shown that for diabetic patients with multi-vessel disease, particularly if you've got a high syntax score, CABG has better outcomes than PCI, and we have to accept that. And a heart team discussion is really important in these patients to try and decide the most appropriate revascularization strategy. But if we are going to do PCI, and doing PCI in diabetic patients can be very appropriate, then we need to do the best job possible. We need to use the best stent technology, we need to use intravascular imaging, and where appropriate, physiology to determine whether we need to be doing anything or not. Optimal antiplatelet agents, both in type and duration, and medical therapy, which has obviously improved substantially for diabetic patients with a GLP-1 agonist and the SGLT2 antagonist showing significantly improved outcomes in patients with cardiovascular disease. One of the other things that we're seeing more and more of coming to the cath lab, patients with renal impairment. And the modern interventional cardiologist has to have a skill set where they can do minimal contrast or no contrast PCI. That means they have to be au fait with imaging, particularly IVUS or saline OCT, and this is the case of saline OCT, and techniques of creating a wire tree, etc., to minimise contrast. Calcium is one of the biggest bugbears in interventional cardiology. It causes problems with device delivery, it can damage devices, lead under expansion, increase complications and prolong procedure times. Fortunately, we've developed a lot of good tools for dealing with this. We have shockwave, we have orbital atherectomy, rotational atherectomy, cutting balloons, high pressure balloons. And with these appropriate use of these devices, we can get good outcomes. But really, we have to decide which devices are appropriate in which setting. And there are a number of algorithms that have been developed, such as this, to indicate which is the best approach. The key feature of all these algorithms is intravascular imaging to really characterize that calcium so we can really understand what needs to be done. Left main PCI, again, this continues to be a problem for us. If we look at bifurcation PCI, the outcomes are worse than non-bifurcation PCI, and if we look at left main bifurcation PCI, there's more adverse events than non-left main bifurcation PCI. And the left main is a different animal. It's a very large vessel. There's a big discrepancy between the main branch size and the side branch size. Both side branches cover a large territory, so compromise of either one of those is important. There's a large B angle. So these properties really make the left main different, and it's essential that if we're going to be doing left main PCI, we choose a stent platform that really has biomechanical properties that are suitable. So we need to be able to expand it to the appropriate size. Often we need differential expansion between the proximal and distal, and we need good side branch access. And of course, imaging is essential. Speaking of imaging, we've had a number of randomised controlled trials that have shown substantial benefit for image-guided PCI, particularly in complex patients. And this led to the statement from the ACC Interventional Council, published earlier this year, which really said that intravascular imaging was an essential adjunct to complex PCI. I'll just show you a case example. So a complex distal left main bifurcation. So what can imaging do? Well, it can tell us about the vessel diameter, it can tell us the lesion length, the lesion morphology, and whether the side branch has significant disease. And if you can see here, the ostial circumflex is severely diseased and heavily calcified. And really that allows us to plan our strategy. So in this case, we can see what we need, calcium modification of the nodular and concentric calcification. So we chose orbital atherectomy, and that the ostial circumflex disease puts us at high risk of compromise of the circumflex. So we chose an upfront two-stent strategy. By implementing that planned strategy, the orbital atherectomy two-stent strategy allows us to get an optimal outcome, and we can check that with IVUS. So we can check edge dissection, we can check apposition, and we can check expansion. Bleeding has important implications for prognosis, and this is a problem following PCI. Obviously, there's been a lot of work around the risks of bleeding, and the ARC consensus statement really allows us to easily identify people at high bleeding risk. And as you can see from this work, that the more bleeding risk factors we have, the more bleeding we get. And so it's really important to modify antiplatelet therapy, shorten that in high bleeding risk patients to 1 month. But of course, if we're going to do that, we have to use an appropriate stent platform. We're often seeing patients with a lot of diffuse disease, and there's important work in this field which really shows the importance of a physiological pressure wire pullback. So if we have a predominantly focal pattern, then we can get good results from PCI, but if we have a diffuse pattern, then PCI really has pretty poor outcomes, and we need to think about, is that the best revascularization strategy? Surgical turndown cases can be some of the most challenging cases that we do, but this paper demonstrated that if we get successful revascularization, then we can have a major impact on quality of life. Unfortunately, it also demonstrated that there was a high complication rate in these patients. And so one of the real challenges is to try and do these PCIs in a way where we're going to get optimal outcomes, both in terms of efficacy and safety. We were really interested to try and push the boundaries and say, look, if in this complex patient set, if we take a state-of-the-art stent, we use optimal revascularization techniques and optimal medical therapy, what outcomes can we achieve? And so we did a registry of 100 patients using the Cre8 EVO stent. They all had complex lesions, at least one complex lesion, and followed them for a year. Now you'll see that 70% of those people had ACS. They were truly complex. So if you have a look, a third of them had severe calcification. Almost a third had a bifurcation. 75% were long lesions. 19% were CTO. There was in-stent restenosis, osteal lesions. So really a very complex lesion set. We used liberal use of pressure wire. 72% of people had intravascular imaging, and 10% had calcium modification. And by using those techniques with a good step platform, we were able to get 100% angiographic success. There were 2 periprocedural MIs, so a very good immediate success rate. But more importantly, we had good long-term outcomes. So at 1 year, there was only 1 in-stent restenosis, there was 1 cardiovascular death, and 1 spontaneous MI. So in summary, if we use the right tools, the right techniques, optimal medical therapy, we can get optimal outcomes in even complex patients. Thank you.
Thank you, Scott. That was terrific. I think it was a very comprehensive overview, and thank you so much for also sharing your own experience and personal data. Now, you brought in a lot of good points that we're going to touch upon throughout the case presentation. So without any further ado, it's my privilege to call upon Professor Kim, who is going to present us the case. So we would actually stop at the angiograms, then we would discuss, panel discussion and audience discussion ideally, and then we close the case.
No worry about that.
Wonderful.
Thank you. Today I'd like to talk about the benefit of the Cre8 EVO for the complex PCI. This is my disclosure. So let's have a look at my case. A 59-year-old gentleman referred to my clinic due to the effort angina since 4 months ago. 2 years ago, he got a PCI with 3-stent implantation in the RCA and the circumflex artery. So regarding the antiplatelet treatment, he got a 1-year DAPT, including aspirin and the clopidogrel, and then they keep the aspirin alone for 10 months. Underlying disease was diabetes and hypertension and dyslipidemia. So 2 years ago, he got his initial angiography showed critical stenosis in the mid RCA and diffuse severe stenosis in the circumflex artery. So successful PCI was done with 3-stent implantation, as you can see. However, 20 months later, patient complained effort angina, so follow-up angiogram was done in the other hospital where PCI was performed. So angiography showed that there is no restenosis of implanted 3-stent, but disease progression of LAD and the D1 and the D2 branch was observed at this moment. So after follow-up angiography, patient visited my clinic by himself to want to do revascularization. So this is my last slide for the case presentation. Before this, my treatment. We plan to perform the PCI for the complex LAD diagonal lesion, as you can see. And regarding the diagonal branches, the D1 branch was absolutely big vessel, and the D2 branch is not small things. So this is my last slide, and happy to discuss is how I treat.
Wonderful. Thank you so much for the case presentation and for stopping here. Let's open a bit the discussion in the panel, and anybody in the audience is more than welcome to actually ask questions or provide comments. We have even microphone here. Let me know if I need to rush to you. Let me kick off with you, Scott, because you actually said what is actually very clearly written in the guidelines, that CABG has to be preferred over PCI in majority of diabetic patients, at least that's a statement from the guidelines. This is a patient in whom there was a prior PCI, but also progression of disease distal RCA. Now we have a complex LAD diagonal lesion. What would your recommendation? Would you consider PCI, CABG? What would be your takeaway here?
Yeah, I think, in the modern state, we always discuss these people in a heart team meeting. And obviously in Asia, there are some cultural, issues around CABG, and that patient preference plays an important role. But at least we should get a consensus opinion about what we believe the best revascularization therapy and present that to the patient. This is complex. There's two large diagonals involved. The first diagonal has a long segment of side branch disease, so it would fit the definition criteria. So I think it would be very reasonable to have that conversation and then present the findings to the patient.
Absolutely so. And most likely, Professor Kim had our team discussion, or perhaps the patient drove the decision, which is absolutely fair and legitimate. So let's tackle the second point. We have a Medina 111, to the best of my understanding. Rino, would you go for a single provisional stenting approach? Just stent the main vessel and see how the side branch looks like? Keo, keep it open? Or would you rather say, look, it's diagonal, it's not so small, so I would prefer to get a stent there as well?
The only sure thing is not cabbage, first of all. And I think that I would start with a single crossover, because the angle of the side branch it's very large, and it's about if I am not wrong, about 90 or 100 degree. Thus, I think that you can try to make a single. I would try to make a single crossover, and then you see. Because the diagonal is a very strange branch, because it's a start very large and then it's very small. Thus, I think that, but the first half of the diagonal branch it's large. Thus, I think that if the single crossover is not sufficient, I think that the two stenting. I love crush technique in any case, but this is my personal problem. Or crush technique or a culotte, because you have to cover the first part of branch that it's a 90 degree, and then when you are sure that you have well covered it, you can implant the stent in the main branch. That's or crush or culotte.
Thank you, Rino. Rafa, it seems to be a sort of a suitable lesion for a T-stenting. Would you go for a bifurcation stenting or single stent? And if two stents, which technique would you go for?
Yeah, in Asia, they have very good results with decay crash and this, but we saw yesterday the long-term outcomes of the ABC main. So I think that probably today the best answer should be go for one stent, and if not, go for the second. Of course, with imaging, but nowadays that we have very busy cath labs, I don't know if we go for one stent and the result is fair enough. Honestly, probably we will be like that. If we go for the two stents, of course, you need the imaging guidance.
Yeah, I like your honesty and transparent answer. So, Professor Kim, the ball is back in your camp. Go ahead and see. Let us know how you treat that patient.
Okay. Let's have a look at that. So my strategy is number one is regarding diagonal D2 branches. POBA will be planned to just keep the TIMI flow as same as pre-PCI condition. And at that time I already decided to perform the two stenting technique. And in terms of my two stenting skill, I have more confidence is mini crush than the DK crush. So mini crush two stenting technique will be planned at this moment. And I really keen to the image guide, but at that time, patient refused the image guidance because patient should pay $1,500 for the IVUS or OCT in the South Korea condition. But it would be very nice chance to have a look at the potential benefit of stent marker with Cre8 EVO for the angio-guided two stenting. So fortunately, wiring into the D2 branch is not too much difficult, so POBA was done with 1.5 semi-compliance balloon in each diagonal branch, and the follow-up angiography is like that, as you can see on the right panel. Then the POBA was done with the 2.5 millimeters NC balloon in the D1 branch, and then so we plan to put the 2.5 by 16 millimeter Cre8 EVO in D1 branch. So implantation was done with the minimal protrusion into the left main. So post dilation with the NC balloon at proximal segment is really, really important step during the mini crush technique because it makes stent expansion to get easy rewiring. So after crush the stent. So D1 stent was crushed by 3-point bi NC balloon. Angiographically, so stent marker and visibility of Cre8 EVO demonstrated is well crushed D1 stent, as you can see. So I think this is one of the benefits of the Cre8 EVO, whether well crushed is well or not. So at the time, we planned to another Cre8 EVO 3.0 by 33 millimeter in the proximal LED. So after implantation, on the right panel, you can see the 4 markers in the 2 stent during the follow-up angiography. So after post-dilation and the POT was done, and the follow-up angiography after POT was like that on the right panel. In the next step is, as we know, is the rewiring. It's during the mini crush technique is the 2 distal rewiring is not recommended, but it's the first I'm trying the rewiring. Its wiring seemed to be too much distal, so I try to rewiring again is by stent marker navigating, and moreover is a cell shape of Cre8 EVO is a rectangle, so it could lead to get easy wiring as well. I think. So after rewiring is every step is easy peasy lemon squeezy. So it's a KBT was done with 2 NC balloon. And I'm very happy to the final angiography compare with the initial angiography on the spider view and the cranial view and the spider view as well. So on the next day is the troponin and the myocardial spec was good, and the 1 month treadmill test was nice, and the LDL cholesterol is 38 milligram per deciliter. So this is my last slide on my presentation. With my several experience with 2 stenting technique with Cre8 EVO, so unique stent marker of Cre8 EVO can help to perform the complex bifurcation PCI in terms of number 1, confirming well-crushed stent, and number 2, navigation of rewiring of side branch stenting with rectangle cell shape. And number 3, stenting where you want, even by angiography guidance. Thank you for your attention.
Thank you very much. That was really an excellent case, and I have to say, after having seen your result, I would have done the same. No, it's a joke. To be honest, I think I would have also used the 2-stent technique in this very large diagonal vessel. So can you a bit elaborate on the importance of these stent markers? Because in fact, this is quite unique. Actually, is unique. There are no other DES, to the best of my knowledge, that have the stent markers. You showed that a wonderful case on the use of markers to help you select the proper place where to cross the strut with the wire and to get into the side access. Can you elaborate on what could be the potential advantages of these markers in other different lesion subsets?
So it's another benefit of stent marker is when is overlap the stent. So sometimes it's too much overlap is not good for the patient. So that time it is very, very useful. Just in my case, it's just a minimal is overlap using the stent marker is good for me.
Yeah, absolutely. So I was looking to the videos that you kindly showed to us, and the easiness with which you were crossing to go into the side branch is quite impressive. Is it because you are a good operator? Is it a lucky shot, or is the stent suitable really for bifurcation?
Yeah, at the time this is the first case of my 2-stent technique using Cre8 EVO. So at that time I'm a little bit worried about this rewiring, but I have no idea. But this wiring is absolutely nice. So yeah, that's why I think Cre8 EVO is advantage.
Wonderful, thank you. We have a question?
Yes, Professor Kim, we have a question from the audience. Let me read it for you. What do you think about a hybrid approach with a drug-eluting balloon on the side branch?
DCB is one of the good option, but I just make sure is that even is a two stenting is well performing two stenting is good, is better than the DCB, I think.
Yes, I agree. Maybe I would have opted for a one-stent stent strategy up front, from the proximal LAD to the mid LAD, and then after a kissing balloon dilatation, do a DCB to the side branch, because if I saw correctly and I remember correctly, use a 2.5 stent in the side branch, correct? 2.5 millimeter, yes. So 2.5 is on the verge of being a small vessel, so probably a DCB would also have been a good idea with less metal. But I agree, your result is excellent. And after seeing what you did, just like Marco said, I would have done the same.
Yeah, because I don't worry about this next step. Just during my procedures, sometimes the side branch is using the DCB. A critical dissection was observed, but the patient is unhappy and I'm unhappy. So just to make sure this two stenting is the well performing two stenting is the best, I think.
Wonderful. Last quick question, quick answer is the fact that you have chosen a two-stent bifurcation technique, a driver for you to prolong the APT. Would that impact your decision making with respect to the APT? Yes or no? Yeah,
in this patient I performed the angiographic guided two stenting, so I have no choice. It's a long DAPT, but if I use the image guided PCI, just 1 year DAPT is enough, I think.
Okay. But even if it's a stable CAD patient, so the guidelines, at least in Europe, say 6 months is more than enough in this
I have a small heart.
Okay, okay. Only one. Yes, okay.
Marco.
Yes, please.
May I
yes, please,
make a question very quick? The problem in bifurcation lesion is that when you start, you have a strategy in mind. Thus, you started with the two-stent technique, and it was very good strategy because the result was very beautiful. But if you start with the one-stent strategy, you have to change something if you have to implant the second stent, because in some cases you cannot make a mini crash, you cannot make a culotte, and thus you are very forced to make just one strategy. The important thing in this using this stent in bifurcation lesion is that it's very comfortable, it's very useful, the markers are very useful to implant two stents, but even in the one stent technique, you have a particular structure of the struts that if you perform a very good pot, you can avoid to implant the second stent, you can use a DCB. Yeah. The problem is with two-stent strategy, if you start with two-stent strategy, you cannot change. If you start with one-stent strategy, you can change your strategy except for some particular technique like crash or culotte.
Yeah, but I believe that is two stenting with the Cre8 EVO result is the good for me.
And I think you're right. You did the procedure wonderfully well. Thank you, Professor Kim. So now we transition to the second case. And we have a frequent flyer in this session with Rafael Romaguera. As you know, Rafa is the PI of the sugar study, and actually he's going to present today for the first time, to the best of my understanding, Rafa, correct me if I'm completely out of place, for the first time, the 3-year result of the sugar study.
Thank you, Marco, for the presentation. I think we both are frequent flyers in this meeting. These are my disclosures. So this case is a 70-year-old male with type 2 diabetes. He has a very sick patient with 9.7 glycated hemoglobin. He has a very high cholesterol, and he was overweight. He also had chronic renal failure, severe sleep apnea, peripheral vascular disease, and he was treated in another center a few years ago with a Cypher stent, a first-generation drug-eluting stent in the LAD, and disclosure, we don't know which was the brand of another DS in the distal RCA. At this point, the medical treatment was I think, very bad. He was only treated with aspirin, enalapril, and a sulfonylurea. He didn't even receive a statin. And he was admitted in our center due to inferior non-ST segment elevation myocardial infarction. First, transthoracic echocardiography showed mild LV dysfunction and inferior wall hypokinesia. So he underwent urgent coronary angiography, and this is the left system. You can see there the cipher, which is widely patent some years later, and diffuse disease in the first septal branch, distal LAD, diagonal branch, and also a chronic total occlusion of the circumflex branch. This was the right. As you can see there, there is the stent on the distal part is patent, but on the ostium there is a very tight lesion, and on the mid-right there is also a significant lesion, both of them severely calcified. So we decided to undergo PCI. The LAD was patent. He had two-vessel disease with patent LAD, and we decided to do IBUS-guided PCI. We predilate with non-compliant balloon, the mid-right and the proximal right coronary artery, and then we implant a synergy stent on the mid part at 10 atmospheres, and then a science stent and the ostium overlap at 20 atmospheres. After that, we did post-dilation of the proximal part with a 3.75 non-compliant balloon. And the final IBUS, this is the final angio, show a fairly well result with the stent well expanded and well opposed. So the patient was discharged the next day without any periprocedural MI. He was treated at this point with aspirin, ticagrelor, metformin, a GLP-1 agonist, enalapril, beta blockers, and rosuvastatin. I think this treatment is much better for him, in addition to the stents. And he did well, but after 11 months, he came back to our hospital due to unstable angina. He started a few days ago with progressive angina, so with negative troponin, so we decided to perform a new coronary angio. The left system was quite similar to the previous one, but as you can see here in this angio, we can see retrograde flow to the right coronary artery, so we suspected something wrong was there. And this was the angio, as you can see on the right, with a severe restenosis on the ostium, also progression in the mid segment. And after predilation with a 2O balloon, we saw a severe restenosis on the proximal part with heterogeneous neointima, suggesting inflammatory component of the restenosis, and we didn't show any other cause of the restenosis. We didn't show under expansion, stent fracture, or any other cause.
Would you perhaps mind stopping here? We shortly discuss the case. This is an embarrassing patient from multiple ways in my understanding. Embarrassing because first generation DS did better than second generation DS. Embarrassing because it's a frequent flyer in the cath lab, unfortunately, but LAD is not diseased, right? So there is actually, we can discuss as much as we want, but there is no evidence this patient should undergo surgery. So how would the panel tackle this case now? Patient keeps coming back with a lot of intima hyperplasia.
Yes, we also have a question just now that we received on site that why was this patient not referred to surgery?
To begin with.
Yes.
Yeah, it's too late for us.
Yeah, now it's too late, but at that time the LAD was patent, and usually we don't, in our center, we don't refer patients to surgery with the circumflex that, by the way, was very small branch and the right.
Yeah, and if you have a look at the distal right, there's very diffuse disease in the distal right, which would, not necessarily be a good candidate for grafting. I think, this is, if you look at my talk, you did everything we talked about. You optimized the stent, the IVUS was very, very good, the expansion was very good, you started them on appropriate medical therapy, but unfortunately this is the result. And it's very interesting, the OCT, that it really looks like there's an intense inflammatory response proximally, but also it's diffuse proliferative in stent restenosis extending right back the ostium. I guess one of the questions becomes, drug-eluting balloon versus restenting. But usually in this sort of situation, it's hard to get a good result with a drug-eluting balloon. So I'd be interested to see what you do, but I would have favoured restenting.
Yeah, I agree. Ostium of RCA, DCB is probably not a good option. Go ahead and show us the case.
Yes, I agree. We don't see any cause of restenosis that we can treat with properly with post-dilation and then drug-coated balloon.
Apart from the stent, yes.
We could try to avoid a multi-layer of stenting, but at this point we consider that there is a severe inflammation due to the metabolic disease of the patient. So we went with pre-dilation with a non-compliant balloon at high pressure. Then we implanted two Cre8 EVO 3.5 by 16 stents, and then we post-dilate them with NC balloon at 25 atmospheres. We checked by OCT. The results were very good, and this is the final result. As Scott said before, if you consider this patient for surgery, he has the distal stent and very severe disease on the distal part, so we cannot graft this patient probably. The result, the angio is very good. So we discharged the patient. He did very well, without any re-hospitalization. He remained asymptomatic. Indeed, he lost 12 kilograms, probably with help of the GLP-1 agonist. And indeed, the glycated hemoglobin dropped from 9.7 to 7.6. It's not perfect, but I think it's much better than before. And 4 years later, he complained of chest pain with negative troponin. Someone considered that he had a previous ischemic heart disease, so they indicated a coronary angio. And this is the coronary angio. The left system is quite similar, the patent cipher, the chronic total occlusion of the circ, and on the right, the Cre8s were perfectly patent with the distal diffuse disease that we described before. So why we choose this stent? As Marco said, we have studied this stent in the reservoir trial and in the sugar trial. This stent has a different drug release with a formulation with a carrier. It's very thin strut because the total device thickness, because it doesn't have a polymer, is much thinner than other stents. So we have a very thin device thickness without any polymer, with a drug diffusion that is enhanced by a carrier. We tested this in the sugar trial. This is the first year result. As you remember, we published it in the European Heart Journal. There is a significant reduction in the primary endpoint of target lesion failure of 34% of events, which was significant for superiority. At 2 years, we have few more events on the Cre8, so this, in this case, it lost the significance. And now, for the first time, we present now the 3 years follow-up. With the help of the collaborating centers that have done a big effort to have the results ready for the PCR. And at 3 years, we have got some more events in the Onyx, so the reduction is now 24% of the events. The most important thing is the absolute reduction doesn't change from the first year. We have the p-value that is not significant, but I think that the results are quite impressive. So this is the reason we choose this stent for treat this patient with a restenosis, with diabetes with a very inflammatory disease. This is the components of the primary endpoint. Of course, they are not statistically significant because the study is not powered to show superiority in the components of the primary endpoint, but there is numerically lower 1 to 1.5% less cardiac death, target vessel myocardial infarction, and nearly 1% less target lesion revascularization at 3 years compared to the Onyx. So to conclude, diabetes is a systemic disease. We should treat the whole patient. We cannot just stent him and leave him without statins, without the new antidiabetic drugs with severe obesity. If we are going to treat the lesion, we have to use the better stent that we have for these cases. The Cre8 have unique features with the reservoir, with the drug release with a carrier. And with this technology, we have shown that Cre8 EVO reduce the events at 1 year in the target lesion up to 1 year, and the follow-up at 3 years is excellent also for this stent. So thank you so much.
Thank you. Thank you very much, Rafael, for the nice presentation, but also for having shown for the very first time the 3-year result of the sugar study, which is first time for me as well. So I was really intrigued by your data, and the key question I have for you is whether you have information about target vessel-related MI. Because if you go back to the histogram you were showing before, the absolute delta for MI is even greater than the absolute difference for TLR. So this is a quite interesting finding, and the same would be true for cardiac death. So do you have the myocardial infarction adjudicated into target vessel-related versus non-target vessel-related?
As you know, most of the target vessel MI in a stent study are very procedural. So this is not a spontaneous target vessel MI, this is all MI. So most of these are very procedural. That's the reason most of these MIs doesn't have any revascularization.
Okay. Rafael, let us understand a bit and put the results into context, because this is, to the best of my understanding, but you are the expert there, the first time an RCT is showing that one specific second-generation DS is better in diabetic patient. Is it true, and how do you explain the finding?
So the most worrying thing is that being hundreds of millions of patients, there are no studies on diabetes. So this is the first and only study in diabetes. We have studies of Manel Sabaté, of BMS versus Cypher. Yep. Then we have the Tuxedo, first generation versus second generation, but there are no more studies. 30% of patients coming to a cath lab has diabetes. We don't care about that. So the only data that we have before is subgroups of bigger studies that are mainly empowered to show differences. But I think in this particular case, the technology is different. So comparing drug-eluting stents that have the same technology, probably the final outcome will be quite similar. They said that the Biolimus is more lipophilic, but the drug is quite the same. Instead, just a radical that is different, but the drug is mostly the same. The technology of release is the same, and the studies that have studied that are empowered because they are sub-studies. So this is the only true study that we have comparing DS, second generation DS in diabetes. And the reason, I think, is that we have a different release technology. So we have less events during the first year. Then after the first year, we just have metal, so we cannot have differences between the stent. So after that, the curve should be parallel. We are treating the pneumonia, but we are not treating the patient. We give the best antibiotic, but then the patient will have a new event because he has a very inflammatory disease.
Yeah, but I think there is no catch-up either, so this is a good result. Basically, the benefit which is occurring in the first year is maintained throughout the time.
If you see other studies of TAVI or whatever, the curves are doing like that, so that's artificial. Depending when you are cutting that, the differences are significant or not. The main thing is that we have seen here that at 3 years the curves remain quite parallel.
Okay, so we are getting a bit short of time, but a quick reaction from the panel. Is this the stent that should be preferred in diabetic patients? Or you don't care because you don't like the study, you're not interested in the study? What's your reaction?
Definitely. The only one that we use, at least I use, and the younglings that I teach in diabetic patients is this stent.
Professor Kim, in Asia you have a lot of diabetic patients, unfortunately, so you leverage on the importance of markers. Would the presence of diabetes be a driver for you to select this stent among others, or?
Yeah, as he mentions, there is only one study for the diabetic patient whether which stent is the better. So in South Korea, the diabetic patient is 40% in the HS patient. So it is the best choice. Is Cre8 EVO for the diabetic patient.
Thank you. Rafa, thank you so much again for the great presentation and the great data, by the way. So it's now time to transition to Professor Sardella from Rome. He's going to bring us through a different case, and that case will give us a different flavor. Thank you, Rino. You're also a frequent flyer, by the way. So,
Thank you, Marco. Thank you to the organization for the invitation in this outstanding symposium and with this outstanding panel. This is my potential conflict of interest. The complex patient. The complex patient is a summary of these two different features. A clinical complexity, whereas the HBR, high bleeding risk, it's one of the major players, and the anatomical complexity. Calcified, bifurcation, multivessel, CTO, left main. All we know the ARC HBR criteria, we need one major or two minor criteria to classify the patient as HBR, high bleeding risk patient. And this is one of our paper with Marco too, whereas we classify the complex PCI according to these features: 3 vessel or more than 3 stents implanted, more than 3 lesion, bifurcation, more than 60 millimeter length, and chronic total occlusion. The case: 85 years old male, hypertension, diabetes, previous LID and first diagonal branch and first obtuse marginal stenting in 2004 and 2010, malignant colon neoplasia treated by hemicolectomy since 8 months, and prior bleeding or transfusion. Thus, according with the HBR criteria, we have 2 major, 2 minor criteria. For this reason, the patient was classified as HBR patient. The patient status: clinical presentation, stable angina, CCS grading scale 3, and at the echo normal left ejection fraction. This is the basal core angiography. You can see the right coronary artery. The dominance was balanced. The right coronary artery was diseased, but it's not so big. And you can see a very calcified LAD long lesion, 90% LAD at the ostium, non-stent restenosis. You can see the stent that it was previously implanted in the mid part of LAD. 70% LAD and first diagonal, non-stent restenosis on first diagonal, that it was in bifurcation. First obtuse marginal in-stent restenosis. And 70% of distal left circumflex Cinta scores was 33. Thus, this patient it was classified as, for several reasons, as high ischemic risk patient. Stop here.
Thank you, Rino. We then open the panel discussion, and anybody in the audience would need to have a comment. We would welcome it as well. So, Scott, again, reverting on to you. The 33 of Cinta score, diabetes is a class 1 indication for CBG, yet is 85-year-old gentleman with a lot of comorbidities. So,
no, he definitely would not be going to see ABG. You know, these are the difficult patients that we have to deal with in the cath lab, and you know, PCI. The question is, you know, do you PCI everything, or do you be a little more selective? But certainly, you know, the LAD is very, very important. You can argue a little bit more about the right coronary artery, how important that is to treat. But I think here, you know, the goal is quality of life and longer term, you know, survival after 5 years is less of an issue.
I probably would stage. To be honest, I don't know what I would begin with, but I would not probably treat all 3 vessel disease in one setting. Any other reaction from the panel before we let Rino continue? Okay, Rino, go ahead.
Okay. Rafael asked to me to review. In case of PCI, other 2 questions: which vessel to start with, multi-stage or one stage? But finally, the surgeon refused the patient due to cancer and need of transfusion, but above all, the patient refused the surgery, and the surgeon too.
So they like each other.
We were forced to make a PCI. Thus, all the discussion was useless. Thus, we started with the first obtuse marginal restenosis. We implanted a drug-eluting balloon, 2.5 for 15 millimeter, and then we implanted the long Cre8 EVO stent, 3 for 33 millimeter in the distal part of left circumflex. This was very good final result. But now we treated the LAD. Above this, we did an imaging. We are very used to make imaging before to make a debulking, because we believe that is in this patient it was very calcified lesion, that for this reason to choose the bulking device in terms of shock wave or rotablator or orbita, we are used to make an imaging. And you can see in the LID OCT the amount of burden of calcium, you can see here with a very, very tight stenosis. Thus we perform an intracoronary lithotripsy with a shock wave, for 12 millimeter in the middle and the proximal part of LID included the left main. We perform another imaging, after the IVL to see what IVL, the result of the IVL. You can see in this frame the cracking calcium in the mid part, and in the other this frame the cracking calcium in the proximal part. Thus we implanted 1, 2, 3 Cre8 EVO stenting, 2.75, 2.5, 16 millimeter, 25 millimeter, and 40 millimeters. Thus we did a sort of full metal jacket with the Cre8 EVO stenting. This was final OCT. You can see the perfect, was very important with the 3D. You can see the perfect apposition of the stent and the perfect opening of the side branch when we treated the LID in close to the side branch. This was the angio final result. This was very good, and the patient, according with the classification of HBR, was discharged with short DAPT, clopidogrel plus cardioaspirin for 29 days, beta blockers, and after 1 month, he would suspend the cardioaspirin to continue with clopidogrel alone. But the devil did its job. The unexpected event, after 15 days, the patient fell down at home and was hospitalized, and he experienced a cerebral temporal hematoma. For this reason, from our neurosurgical colleagues, the DAPT was entirely suspended for 9 days. That is, this patient remained 9 days without any double anti-aggregation therapy. After 2 days, the patient complained of chest pain without modification and troponin arising, and the patient primarily refused the coroangio that he accepted 7 days later after some strong push from us. But we think that it was mandatory to make the coroangiography. And the angio the result was perfectly maintained, no DS procedural related issue. But what is that the coroangiography was performed at 30 days follow-up. But what is very interesting is the 33 days OCT imaging shows already 87% of struts coverage. And the main percent of struts coverage, it was in the Cre8 EVO stent and not in the first stent that it was implanted in 2004 and 2010. Thus, a small take-home message. The new Cre8 EVO architecture offers outstanding performance in challenging lesion, showing a superior crossability. This was a very calcified lesion, and excellent trackability. The lack of polymer avoids inflammatory triggers provided by the polymeric presence, while the bioinducer surface minimizes prothrombotic stimuli and promotes a fast stent struts coverage. About 50%, 49% of patients in registry and randomized control trials are at HBR, meaning that the prevalence of HBR patients in the PCI population could be higher than we think. The Cre8 EVO stent securing the safety, very short DAPT, in HBR expected, but what is very important, unexpected patients, respects the concept that PCI efficacy versus safety is an interconnected equation. Not only safety, not only efficacy, but safety and efficacy together. And finally, in my daily practice, the Cre8 EVO stent has shown the DAPT can safely be interrupted at 1 month in HBR at even earlier if you need in case of unexpected clinical circumstances. Thank you for your attention.
Thank you very much, Rino. So the DPT was suspended for 9 days, and then what did you restart? Aspirin, clopidogrel, or nothing?
Clopidogrel.
Okay, it was left on clopidogrel monotherapy. So very sobering case. Actually, nice case to show the excellent performance in terms of efficacy, then also safety of Cre8 EVO, but also sobering case because, of course, you did what you could do. You followed the guidelines. You gave 1 month DPT, and despite this, in that month, the patient fell down. Yeah. And then the bleeding that is potentially trauma-related, but also potentially related to the regimen.
We informed him to be careful at home, but...
Yeah. So the point I would like to make is that, of course, we have a sort of a dummy approach, HBR yes, no, but it's probably a little bit simplistic, right? There is HBR and HBR, and such an HBR patient, probably even 1 month EPT is probably too much, and that's where we should push the envelope. But also showing how efficacy and safety cannot be disentangled here. So thank you for sharing this case with us. Any comments from the panel here with respect to this case? Rafa, perhaps to you, what is the DAPT regimen that was recommended in sugar study?
The inclusion of the sugar was before your study, Marco, before you saw your results. So our recommendation was 1 year for acute coronary syndromes and 6 months for stable patients. So nearly 53% of patients for Cre8 and 59% for Onyx were still on the APT at 1 year. There was a 50% acute coronary syndrome on sugar, so right, that's the reason.
And Scott, perhaps a question for you. So we heard about the stent coverage already so complete at 1 month. Is it a credible endpoint? Would you feel confident in stopping DPT after 1 month based on this piece of information?
Look, I think it's an important part of endpoints. One of the problems we've got is that we don't have large trials that are powered to look at stent thrombosis between 2 stents, and we'll probably never get those because of the size of, it's required. So therefore, we need to look at surrogate endpoints about how these stents perform. And whilst it can't give us the complete answer, if we do see good endothelialization, we do see good coverage early on, it does promote some confidence.
Yeah, I agree. Thank you, Rino. I think it's 2-3 minutes to the closing line, so let me close the session. In fact, I think all these 3 cases were pretty impressive, to be honest, and they speak for the efficacy and the safety of this stent, which is really amazing and has for sure a niche in diabetic patient. The key point, I'm not showing the disclosure because since then I have not changed. Why should Cre8 EVO work so good in diabetic patient where there are many biochemical reasons to believe that is actually the case? The diabetic patients have sort of a resistance to uptake sirolimus, and you may recall back in the old days of first generation DS with the Cypher stent, where the efficacy of Cypher stent was lower in patients with diabetes. Therefore, the company decided to double the dose of Cypher, and unfortunately that did not work because that was associated with the necrosis of the media of the vessel, and this result of the body 2D got published very lately, but basically failing to show that increasing the dose of sirolimus would do anything better. So the approach that has been taken by Alvimedica and Sorin before in trying to overcome this insulin resistance, sirolimus resistance, is to actually put the sirolimus in association with a carrier, which is a fatty acid, to which the diabetic cell is most eager to, and therefore by by uptaking the fatty acid, sirolimus got more into the diabetic cell, and this may explain actually because the stent has such a wonderful performance in diabetic patients, or in other terms, diabetes seems not to be a modifier with respect to the stent performance, which is clearly not the case for all other DES. And that's why these amphibous formulations, this combination of this sirolimus and fatty acid makes particular sense in patients with diabetes. And I have to say the sugar is quite a convincing study on top of late loss studies, which Rafa actually performed before it. So I think now the story is quite sound and clear. What are the key learnings of this session? I think there are persistent benefits in terms of lower TLR in the sugar study at 3 years. This is really a highlight of the session. We have been exposed to this information right now, and that's key implication for us to practice. We discussed and seen how the stent markers can make your life easier. Sometimes you have an ideal patient in which probably don't need to have stent markers, but most frequently you have to be careful about contrast injection because of CKD. The patient is obese, so having the markers in the stent actually can be quite handy. And I have to say this stent is unique with that respect. Cre8 EVO has the advantage of being very effective in terms of late loss in diabetic patient, but if unfortunately DPT has to be stopped, as we have seen, seems to be very safe, and that's really important information. And finally, Reno's case is sobering because unfortunately it brings us a reality which is in front of us every day. We cannot disentangle efficacy from safety. High bleeding risk patients are frequently high ischemic risk patients and vice versa. So having a stent which is relatively insensitive to DPT presence and duration is probably key to optimize outcome of our patients. So with that said, I really would like to thank all our faculty. It's been a great session and I learned a lot from you, and to the audience for your participation. Next time, try to be more active. Thank you very much. Have a good